Thank you again for this invitation to speak regarding care hacks for the ER doctor. Um, this is my warning. It's going to be painful. I lied. There will be no mathematics really, but there will be some strong language. Because when I was preparing for this talk, I was thinking about the easy things that we sometimes miss, and basically the things that make me angry if they are not done. So some of these things may be new, but a lot of the stuff really are a review of things that we should be doing for our patients. So just very quickly, we're just going to go through some pearls, and they're all over there. We're just going to go through them one by one. They're not very many. There are a gazillion hacks in critical care which are applicable to emergency medicine, but we will obviously just focus on the easiest ones and maybe some of the things that should be done anyway. So the first one, let's go start. Do not intubate too late, damn it. Because when you do that, patients die. So one of the things that we have learned over the pandemic more than in recent years has been the use of non-invasive respiratory support. So I'm speaking of BiPAP, I'm speaking of high flow nasal cannula. And generally speaking, patients that need this, a lot of them improve. So when we start non-invasive respiratory support, obviously we would like them to be getting better. So when we are looking at this graph, by the way, you're going to see this again and again during this lecture. So the y-axis is the chance of success. The x-axis is time. And the blue line or the trajectory line is just talking about how the patient is doing, whether they're doing better or worse. And the very bottom in the simplified form, you're going to be looking at the red line is the line of irretrievability. Basically, the patient cannot be saved. Something bad is going to happen to them and you can't do anything anymore. So again, if we are doing non-invasive respiratory support, we are hoping that they're all getting better. And because of our stay in the ER is not actually that long, we may not be able to monitor them for all the outcomes that they have. So that is one of the weaknesses of emergency medicine, is that we are not actually able to see the outcomes of our patients unless they die in the first 24 hours and then it becomes an M&M. So we know that some patients that we put BiPAP or high flow will deteriorate very quickly. And then we know what to do next, which is basically to intubate. But there are some actually that will deteriorate after a little period of time. And I wonder if people are aware about the chances that someone actually gets better or never gets intubated once they are on non-invasive respiratory support. So it turns out that for high flow nasal cannula, the chance of failure is about 1/3 for all comers. And for BiPAP, it's different if it is a de novo or a new onset, acute onset respiratory failure. So there's a higher chance of almost 1/3 to 1/2 of patients will actually fail non-invasive ventilation. Whereas if you've got someone with acute and chronic problems like COPD or heart failure exacerbations, those patients generally do better. So think about it. Around 1/3 to 1/2 of the patients will fail. And one of the things that we did find out was if you intubate too late for the ones that fail, the mortality goes up. So this was a Korean study actually that was done in 2017 or 2018, I forget. And they found that if you wait too long for to intubate someone that eventually failed high flow nasal cannula, the mortality doubled. So we need to find a way to see whether a patient is destined to fail their non-invasive respiratory support. Because if we intubate too late, they tend to die more. So there is also some data for BiPAP. I'm just not gonna flash that anymore. Okay, so we need to look for some kind of markers for to see if we can identify the patients that are going to fail later on. So one of the things that I think will be very useful is this thing called HACOR. HACOR is a scoring system where you're looking at heart rate, acidosis, consciousness, oxygenation, and the respiratory rate, making HACOR. You plug this in, you score it 1 hour into BiPAP or CPAP, depending on the application. And if the HACOR score is greater than 5, you know that instead of the 1/3 chance of failure, you're already at 80%. So basically, these patients are the ones that need to be intubated. So if you don't intubate them early enough, they survive less. So they first looked at this in 2017. It has been a very useful score. There have been many studies that have come up actually during the COVID-19 pandemic. And so over there, we see that if you use CPAP instead of BiPAP for COVID-19, you can use the same scoring system. And it is also associated with an 80% failure rate with a score greater than 5, 1 hour after instituting CPAP. And this is a 2021 study. It is already available in MedCalc, so it shouldn't be a problem for anyone to find this. If you look at high flow nasal cannula, you can use the ROX index. ROX index is a calculation based on the pulse oximetry, the FiO2, and the respiratory rate of the patient. And you can calculate it at several times during a patient's course. So you can calculate the ROX at 2 hours. And if it is, according to that graph, if the ROX score is less than 2.85, you should consider doing an early intubation. And again, you can recalculate this over time. This is also available on MedCalc. So I encourage people to be using this because sometimes, especially during the endorsements to the floors, a lot of information is lost. And we tend to not intubate someone who is not deteriorating right away. But if we're able to figure out ahead of time which ones are going to deteriorate, then these are the ones that we should intervene on early. So if you do decide to intubate, you want to minimize intubation complications. Damn it, because these do happen. In earlier studies, 1 out of 6 of patients could actually die during an emergency intubation attempt. And this probably happened more often in COVID-19. We don't have all that data yet. But so when we do rapid sequence intubation, again, the hope is that the patient does better, but a small proportion of them actually get worse and die, even though we've intubated them, either die or have the cardiac arrest. So if you do this exercise called the pre-mortem, which is basically predicting what kinds of deteriorations are possible for someone that you intubated, you know that the first one is first pass failure, meaning you're unable to intubate on the first attempt, and therefore there's a prolonged intubation. Therefore, more problems can happen, including severe hypoxia. If you're able to intubate, you may have transient or sustained hypotension, depending on the amount of preload that the patient used to have. And then you can have dangerous arrhythmias that happen. Either a vagal event can happen, or you can trigger other arrhythmias in the patient. So this is a protocol that they developed. The modified Montpellier protocol was first developed earlier in the early noughties, and then later on modified in 2017. And there are 8 things that you need to do. And 4 of them are about pre-intubation. 1 of them is the RSI. And the third group is about post-intubation. So you want to have 2 capable intubators. And during the time of an emergency, that is not the time for the junior member of the team to attempt the intubation. You want the most capable people to start, to be the ones to intubate. The second one is administering IV fluids, because once you intubate someone, you go into positive pressure ventilation from negative pressure ventilation, and it actually compresses the heart. So you have preload unloading and the blood pressure will drop. So the Montpellier protocol talks about giving fluids, 500 mLs, you run it, you start running it. You don't need to finish running it before you intubate, but you need to make sure that you start running it before you intubate. You only do not do this fluid administration for the ones that are in florid heart failure. The third one is to properly sedate patients, and there are many ways to do that. It's part of our SI2. The fourth one is about pre-oxygenation with one of the non-invasive respiratory support devices, either high flow, non-invasive ventilation, or if you don't have it, a non-rebreather mask. So the second portion is about RSI, and everyone should be familiar with that. And then after the intubation, you want to make sure you're using capnography, not only to figure out whether the tube is in the right place, but whether you are over-ventilating or under-ventilating someone. Some people are going to need vasopressors for shock after you have been giving the fluids. And then finally, you need to plan on the continuous sedation for the patient. Because, from time to time, you do get people that you had a hard time intubating, and then you don't sedate them, and then they wake up and they pull out their tube, and then something bad happens. So if you do this modified Montpellier protocol, the results have been you will have 3/4 chance of a first pass success versus 58%. And then you drop the major complication rates of severe hypoxia and sustained shock from 21% to 13%. And then you basically have the mortality. So this was, I think, an American study, and they had a low mortality during the emergency intubation. In our own data before, we were finding as high as 1 out of 6, or 1 out of 15. Now, if you did do rapid sequence intubation and you know that paralysis is part of it, you have to match the minute ventilation that the patient had. So as a review, minute ventilation is RR times tidal volume. Let's say you a young person comes in and they're breathing 36 times a minute, and their estimated tidal volume that they're breathing for themselves is about 500 mLs per breath. So that makes a minute ventilation of 18 liters per minute. So there was a little bit of math, but I'm pretty sure you can handle that. And then you do an ABG, and then you saw that the PCO2 was 40. So if you plug all this into this graph, which looks at a dead space tidal volume ratio, you will find that this patient fits into this second line of the dead space tidal volume ratio lines. And therefore, if you basically do an intubation with an RSI and then drop the RR to 20 with the same tidal volume, you will now have a minute ventilation of 10 liters per minute, and you can plug that in and you will find that the PCO2 will go up to 70. So that is a 30-point increase in PCO2 that will drop the pH by about 0.24 points. Some people will actually arrest. So you have to be very careful that you're matching the minute ventilation every time you're doing RSI. This is a frequent problem, more frequent than I think just this week, I caught one patient that, again, the minute ventilation was not matched. All right, here's another thing. The Montpellier protocol talks about continuous sedation. So stopping the damn sedation. Right, because the normal thing that happens is if someone's blood pressure drops, the first thing that the physicians at bedside do, turn off the propofol, turn off the midazolam, something like that. Not a good idea. This thing here is a review of all the agents that you're able to use. This was specifically for COVID-19, but it's the same thing for any kind of critical ill patient. And I know it's a busy slide, so let's just talk about some of the stuff. For example, for propofol. So they actually talk here about hypotension occurring during propofol infusion. And if it does occur, and if it persists with the lowest effective dose, meaning you want this patient to still be sedated and not pulling on their tube, you should consider initiating norepinephrine or switching to an alternative agent. There is nothing here about stopping the DAM sedation. Now, if you are still having a hard time sedating someone and the patient is already on propofol or midazolam or fentanyl, morphine is not a good idea for someone who's already hypotensive. The other thing that you might consider is using ketamine. So ketamine will actually increase the blood pressure and the heart rate in some people. The problem might be there might be increased secretions, and therefore you might need to suction more or need to give special medications to dry the secretions. But I have found that so far we have not had too much problems with this one. So you can mix and match. You can put propofol and ketamine together. That seems to be a very popular combination in the US right now, for example. Stopping sedation. Next one is to stay away from the goddamn physiologic cliffs. All right. Let's say you have a patient who has a blood pressure of 80/50, and you're thinking to yourself, okay, I'm going to give some fluids. 5 minutes later, the patient's blood pressure is now 70/40, and then you tell the nurse, hey, okay, let's start norepinephrine, thinking that you still have 5 minutes. Do you guys know how long it takes to actually mix a norepinephrine dose or a norepinephrine drip? It was timed actually, and the average is about 8 minutes. So, but you're thinking, we still have time. Blood pressure is not dropping too fast anyway. But deterioration is not linear. So 3 minutes later, they call you back into the room, the patient's in an arrest. Why does that happen? So there is a cliff. And in this particular case, the cliff is, I think, coronary perfusion. This graph here talks about survival and resuscitation, and we're just going to use it as an example. The right part of the slide talks about end-tidal CO2, and you find that the end-tidal CO2 for both non-survivors and survivors are about the same, about 30. But if you look at the left side of the graph, you find that the ones with a higher mean diastolic blood pressure are the ones that tend to survive. And the reason is the patient needs to have good coronary perfusion, and coronary perfusion is dependent on diastolic blood pressure minus either CVT or capillary wedge pressure. So the cliff occurs at a diastolic pressure of around 40 or 30. And then after that, all compensatory mechanisms fail because the myocardium is no longer being fed oxygen or blood. And therefore, instead of going from 80/50, 70/40, 60/30, how often have you actually heard of an M&M conference where they were talking about a blood pressure of 60/30? You don't. The reason is by that time, the patient had arrested already. You hear about 80/40 and 80/50 or 70/40 a lot as a pre-terminal event or a pre-arrest event, but you never hear about 60/30. That's just a fun trivia. So you want to keep the mean diastolic blood pressure higher than this cliff. And if you know that it takes a long time for you to mix a norepinephrine drip, then you should consider push-dose vasopressors. So push-dose vasopressors are basically boluses of epinephrine or phenylephrine. You should not think about ephedrine. Ephedrine has been used in anesthesiology. It says they're not recommended in the ER because of the extended duration. But phenylephrine, not many people have experience with that. And the most recent reviews of push-dose vasopressors still recommend our good old epinephrine because it is both an inotrope and a vasopressor. And when the compensatory mechanisms are failing, both the heart rate and the blood pressure are going to be dropping. Now, here's the issue. In the US, the epinephrine doses that they use for cardiac arrest come in 10 ml vials already. In ours, we get it from a from a vial, and then we push 10 mLs of fluid after it. So they already have a less concentrated form of epinephrine that is available to them. And then what they do is they get 1 ml of that, they put it in another syringe, and then they add saline. And so they now have 1/100th of what we have as a concentration. Because what they're looking for is a very small dose. Look, 10 micrograms. That's basically a 0.1 ml of not, yeah, no, sorry, that is a 0.01 ml of our epinephrine vial. So we're unable to do that actually, or we're only going to be able to do that with a lot of difficulty. So even if they're asking for about 5 to 20 micrograms, if during the times that I have had to do this, I have been giving patients about 100 micrograms, which is 0.1 ml of your 1 milligram epinephrine dose. So think about this, because yes, it is something that will again hit the heart very, very quickly, and therefore keep you away from that cliff. The thing that I need to remind you of is that this only buys you time. You need to figure out what is going on with the patient very quickly and try to figure out what kind of support they need or what kind of definitive treatment they need so that they get better. This will only work for a few minutes. So, since we're trying to figure out what is going on, we want to define the problems for shock and respiratory failure all the time. And for this one, I am talking about ultrasounds. So for example, this patient, you can see that this patient was hypotensive. You can see from the ECG tracing that they are also bradycardic. And on the short axis view of this heart, you can see that there is a lot of fluid around that left ventricle. The other thing that you see is that the left ventricle is very thick. The cavity is very small. So there are some things that are going on here. Number one, this patient is in tamponade, and there is a large pericardial effusion that is happening there. The second interesting thing is this phenomenon called pseudohypertrophy, where the left ventricle looks thick because it's not able to expand anymore. So the cavity is very small. The third thing that is happening here is the expected compensation for someone that is hypotensive is tachycardia, and yet this patient is very bradycardic. This is one of the Bizol-Jarisch reflexes. So this is a pre-terminal event. If you see something like this, and that's another thing you need to remember, if someone is hypotensive and they turn bradycardic, the patient is about to go into cardiac arrest. So you better push those pressors as fast as you can, or intubate as fast as you can, depending on what is happening. So if you didn't have an ultrasound or an echo, then you would not have been able to diagnose this. So this patient had an emergency pericardiocentesis that we performed ourselves and was able to bring up their blood pressures very quickly after that. Now, ultrasounds may not be very easy. So cardiac echo, you got specialists to handle that. So some of the hard stuff that are being taught that can still be taught or learned actually, even in emergency medicine, includes stuff like figuring out the cardiac output using left ventricular outflow tract PTI, or doing a formal ejection fraction. But there are easier ones. The easier ones, just look at the movements, for example, of the anterior leaflet of the mitral valve. This is the E-point septal separation, and the other one would be mitral annular perisystolic excursion. Very easy things to do. Hardly any measurements that you need to do. You just need to know how to do an echo. So we won't have time to talk about these today, but just letting you know that these tools are out there for the ones that need to know a little bit of sonography, but not too much of it. The other thing which is very useful is a lung ultrasound. So we were talking about shock and respiratory failure. You want to do both of them. You want to do an echo. You want to do a fast, actually, an extended fast if you know how to do it. And then also do what's called the Blue Protocol. Blue Protocol is more than about 1.5 decades old now. And you can actually figure out or generate a lot of differential diagnoses for respiratory failure very, very quickly or rule out diagnoses very, very quickly with this protocol. For example, a pneumothorax. So because sometimes it takes a long time for the x-ray to come down, and then to get it interpreted, for example, you should be able to do an ultrasound very quickly. All right, my last two things are actually not clinical. They're more either procedural or something that the team leader should do. This one is a fun thing that you need to remember. It's not just a catheter. This thing here is a cordis introducer sheath. So we had put this in all the code cards in the medical city. And generally, it's being used for cardiovascular central vein access, actually. So we have trained people to do internal jugular. We've trained people to do a femoral line. But you can use it for so many other things. You can use it as a pericardial drain, because if you are able to wire and put the catheter into the heart, you can do a pericardiostomy. So there was a time before we had a patient with a cardiac arrest with a known pericardial effusion. We were trying to do an arterial line using one of these catheters in the femoral. We just switched over. We prepped the heart, did the drain in a peri-arrest situation, and we're able to drain actually 100 mLs of blood. This patient had like dengue myocarditis. You can also use it as a pleural drain, like a small chest tube, or it may collapse actually because that is a thin wall. But if you're lucky, or if you leave the stiff dilator inside it, you might be lucky and be able to drain either air or from a pneumothorax, or fluid if you really needed to. And because it has a spigot or a three-way stopcock at the very end of it, you can actually control how much air or fluid you are taking out. You can also use it for peritoneal drainage. Obviously, you can also use it as an arterial access. So if you are at the femoral area, let's say you missed the vein, you're trying to hit the vein, but you hit the artery, leave it in. The reason is you can actually transduce that, and then suddenly you have an arterial line. An arterial line is very useful. For cardiac arrest, for example, you can use it to figure out the diastolic pressure of the patient that you are resuscitating. And also, once you have a sheath in, you can now put different kinds of wires and different kinds of devices. You can put the balloon pump through that by upsizing. You can put a wire through it and then do ECMO if you needed to very, very quickly, because you just need to put the wire through it. If someone was using the more advanced technologies for trauma, like the Reboa, that basically uses these kinds of introducers to put in the wires. So this is a very useful catheter. The skills involved are ultrasonography and interventional, just figuring out the needles, and it's not so hard to do. My last little pearl here is to stand in the goddamn right goddamn place. This study came out in 2018 and I missed it, and it's actually a very good one. And they used the findings of this study to be incorporated in the 2020 American Heart Association guidelines. Because if you have been trained AHA ACLS since 2020, you know that they are now teaching a new position in the team called the CPR Coach. We'll not talk too much about that. We'll just talk about the importance of lines of sight. So you can see here in the examples that the chest compressor is able to see the defibrillator, the CPR coach, and the bedside monitor, because if they have an arterial blood pressure, they know that they should be able to press harder if the diastolic blood pressure is too low. The other thing is, for the special defibrillators, you can actually see the efficiency or the speed or the depth of your cardiac compressions, and therefore it's positioned that way. The resuscitation leader on the right side of the slide can see most of the team members and has easy line of sight to the bedside monitors and the defibrillator. So these are the kinds of things that we need to be working on about ergonomics of cardiac arrest. So by doing this, basically changing lines of sight and adopting a lot of technology like the arterial line entitles you to real-time feedback for CPR. They were able to increase their chest compression fractions. They were able to increase the chest compression depth and the chest compression rate. Also because of the CPR coach, whose only role is to make sure that we're doing the CPR correctly. And the CPR coach should be able to see the chest compressor and again, the defibrillator, the monitor. So I am at the end of my lecture. There's not much that is very new actually with what I have spoken about. All of these things have been known before. A lot of them are reviews, and some of them are just fun ways of using equipment that we already have. And the last one is just a relook at how we actually position ourselves during emergencies. If you wanted to learn more about thinking under stress, this this QR code here will actually lead you to the AXI YouTube website where we actually have some of our lectures there. So, and if you have any questions, obviously I will be here. My email is there, and also the Twitter account of the critical care of the medical city. So again, thank you very much for listening. Ask me some questions, please.